I'm humbled to introduce the team. Probably, as they say, the data generator. I'm under the leadership of Dr. Jenna Chibuka, who is by the titles, and she's our Dr. Head ICU. Then also in leadership of the Senior Nursing Officer Critical Care, Matron Martha Lupo. She's unwell there. She's our site leader, and she's the nurse in charge ICU. Two data entrants, that's Dr. Israel, I don't know whether he's in the house now, with myself as also a data entrant. Briefly, that is how beautiful that's how beautiful the Mulago National Referral Hospital is. That is the spring court of medicine. We all know that. So that's how beautiful it is. And that is our ICU. I just took one view, but it's two-sided. That's how it looks at, like from one side with the hardworking nurses around there taking care of their patients. We have the central station in the middle there with central monitoring, but I didn't, time given is little. I never wanted to have most of the pictures. Generally, by description, Mulago National Referral Hospital is a general adult ICU that I'm representing with the biggest public ICU with a bed capacity of 27 beds. However, we are operating mostly at 12. You know all the hiccups and the bottle tops that we get as a public hospital. I don't need to drill on that, but one of them to talk about is human resource. This is majorly a referral from across the country, the private and the public, the Mbararas, the Mbales, the previous presenters. They have few capacities, so they refer to us. So we are burdened as such. It is an out-of-pocket payment with subsidies. You may wonder, this is the public, I've put it there, subsidies. You know how expensive an ICU is when it comes to its consumables, the maintenance and everything. We also have a waiver provision. So don't say government, why not this? An overview about ICRU. It has been in existence since in COVID era. We started in 2021, that is after the first site, that is in Mbale. Then they enrolled Mulago to date. And we have been running such projects. We started with Protect, there's FLUID, ICOPE, all that has been in place, and we are still running the project. What does this mean to us or to the site? We had a great experience here, both always in a learning. You will always have the positives and the negatives, but always there's a leeway to handle things. So on a positive note, we have gained a lot of knowledge and skills in this data kind of entry. Here, skills and also the burdens, which kind of patients are we handling? This prepares us, allows the team to know when it comes to logistics and other aspects, to know really what should we do. So this has brought an insight on this. And also being a nurse, you know, most nurses are here. Always data is our challenge, and research, we have to admit this has been a challenge. But just know, I'm part of that crew. You saw my credentials is just because of this. It has really helped me a lot. So this helps us also to analyze, as I said, an application of data. Just as I summarized, what does it take? What does it inform us as an ICU, as the biggest ICU, when it comes to decision making and other things? Also understanding the structure of itself, the structure of the data. That also brought what? Brought knowledge in that. Social networking. Who knew I would meet you people? It's just because of this study that I can say I became an international nurse, because I would ask across, locally and across. So thanks to the project. Then also details, attention to details. You know, we love shortcuts. But knowing that this data informs and helps us bring out what we really want, you pay to details, you get to know what it all takes to have, I can say, the resilience and the accuracy of having this data done, such that tomorrow when analysis is done, it helps the country and also other countries that are struggling with critical care. Well, I'm too soft. I think the button is hard for me. Someone to help just fell. Oh, okay, I can just use the, yeah. As I said, in everything, there are always challenges and the positive part of it. But I don't want us to dwell here. This project came from far, and there are so many modifications that have gone on, as earlier on highlighted by the previous presenters. At first, initially, it was a complex system where we had so many things to enter, and being a government hospital, you know, there are so many things that are not done, like labs, daily labs. So all that was needed until now we found out that the system is so friendly. We are able to handle it. We are used to it. But at the beginning, it was really tough. Then also the network issues that would affect the synchrony of data. Me, myself, I'm a nocturnal person because during that day, I try to run so many things to develop myself and also do what I'm required to do as a government worker. So I burn most of my nights, and you find that the network puts you down. You've really spent the whole night sitting down to do your work. In the morning, you realize that your data was not scrutinized and you've lost it. And that was at the beginning. But just as they've told us now, things move very well. Then also previously, it was cumbersome to discharge the discharge process of patients in the project. Remember, the data entrance, we all know that before, where ICU is never the final discharge point. You step down, you take to the wards. And we used to have what we used to have as hospital final discharge. And you discharge from ICU, transfer to another ward, then you have to follow up for the outcome in the ward. So with the burden or with the issues of hospital documentation, you may even find that this patient was not captured. But for you, you're looking for the outcome. Then you have to call them because you have your numbers. You call them and you're like, you don't know whether the patient left the hospital alive or dead. But you call, oh, remember your nurse, Esther? I'm trying to follow up on our patients. Then to maybe a regret thing, oh, the patient died. Why are you reminding us this? So that was one of the challenges that we used to face. Then also the expensive bandwidth that is on data. You can sit there and your data runs out so fast, and you know what, you want to do your things and you only realize that you're used or you're bundled and you're still working and you've lost what you entered after your data. Then loss to follow up patients due to the manual record system, just as what I explained, that you may lose out. Then you're forced to call because you have their numbers, and you have to call them to find out and have a final discharge. And that used to have like for a long time, your registry would be crowded. You've not discharged your patient to have a few, but we thank our facilitators. Currently, you discharge a patient from ICU, and it's a smart thing, and it is easy to. And it also helps us to know that at least we discharge patients alive from ICU. But before, because you're following up to the ward, most of the discharged patients would be the ones who have passed on. And you would look at your data and say, do we only lose patients, or we also discharge them alive? So that's what, as this say that without data, you're just another person with an opinion. So with this data, it informs us, gives us the information, and we are able to translate it into you. It starts as the broader thing. You can interpret it in so many ways. You can also have the dots as the scattered thing, that is data which is scattered, and later on you get yourself in the uphill after analysis. Oh, a big thank you.